Welcome to NHS ConfedExpo23. Please welcome to the stage Lord Victor Adebowale, the Chair of NHS Confederation, and Richard Meddings, the Chair of NHS England.
Good morning, everyone. How are we? Good, we're good. Excellent, very good. Welcome to the Vic and Rick Show. Can I just start by welcoming you, actually, on behalf of the Board of Trustees and staff of the NHS Confederation. I'd like to welcome you to NHS ConfedExpo, our joint annual conference with NHS England. For those of you who don't know me, I'm Victor Adebowale, Chair of the NHS Confederation, and it's my pleasure to host you all for the next 2 days. I'm particularly pleased to be in Manchester, the jewel of the North. Yes, I can hear some of you from Wakefield, Leeds, Bradford, going, hang on a minute. But we're in Manchester, and it is a jewel. And to welcome partners, our partners, from across health and care, local government, social care, housing associations, and from the voluntary community and social enterprise sector. Last year, there was a mantra of "We are the NHS." But this year, surely it's "We are partners," as we strive to achieve true integration and population health. I am really pleased that over 5,000 of you have come here to be encouraged, to be inspired, and to solve problems together. And I want to thank our sponsors, Google Health and Accurix, for supporting us to make this happen. I'm hoping that it's going to be a significant time for us all as we head towards some really important milestones. This year we mark 75 years of the NHS. In fact, we'll mark it in July. And there are plenty of stages, issues, sessions for us to engage in during the conference, but it's important to mark that's where we are, 75 years of the NHS. We also mark 75 years since Empire Windrush arrived in Britain, actually, bringing in thousands of people who form the bedrock of our NHS workforce to this day. These are dates to greet with thanks for the achievement of those people, our people, in the NHS. Poignant dates as we reflect on their experiences and their achievements. I want to acknowledge the position we find ourselves in this morning, though. We have colleagues, our junior doctors, on the picket lines again. And for many of those people, the decision to strike has been a tough one to take. And we know there are colleagues who are not here because they're helping to cover. So I think the best way we can acknowledge their efforts is by working, learning, being inspired, encouraging one another, and going back to our organisations as better leaders. And please, yes, feel free. You can greet colleagues. You can do it with a smile. You can even have a drink after work. I just want to say thanks, because this is often done at the end. I want to say at the beginning, thanks to my Confed colleagues, to my board, many of whom are here, my deputy chair, Jackie Daniels, I'm sure she's in the audience somewhere. Where are you, Jackie? Cool, Jack. Thank you for your support, your encouragement, and working with us to make sure that we could meet in this way. Last year was our first post-lockdown conference, and I recognised the mammoth efforts you made to get the country through the pandemic. But I feel it's time for me to thank you again. So, thank you. Because I'm talking to many of you, and many of you recently, this year feels even tougher, doesn't it? So much has happened in a year. And we at the Confed have been working hard on your behalf. We've lobbied for a much-needed workforce plan, which the government committed to publishing this year. And yes, we're still waiting. And yes, we're keeping the pressure on. We've sought to shape the debate around the devolution and the evolving relationship between the centre and integrated care systems, both through the report we commissioned from Professor Chris Ham and by supporting the Hewitt Review. And by the way, we understand the government's response to Patricia's review. It's out today. I can't say anything right now because they'll shoot me. It has to be put before Parliament first, but the indications are that while it won't give us everything, it never does, it will give us enough for us to continue that important work with all of you. We've also supported you through NHS employers by developing comprehensive guidance to help you face the pressures, particularly of the industrial action across the NHS, while continually urging both the government and unions to resolve the ongoing disputes. And I'm sure you'll be hearing more from Matthew and Mr. Barclay when he's interviewed tomorrow. So, you know, yes, the ConfedExpo, it's an opportunity to recharge, refocus. But I want us to challenge ourselves to talk about some of the really difficult issues that we face. And yet, it's going to be uncomfortable. It should be uncomfortable. Some of these issues are uncomfortable. I believe that if we're not feeling comfortable, we're probably not trying hard enough. Some of you might be familiar with the Gleicher-Beckhardt change formula. Those of you that aren't, I'm going to give you it now. It's a cracker. Change equals discomfort times vision times a credible first step that has to be greater than the resistance. That's why difficult conversations have to happen. But they also have to happen because the future is decided by the things that we don't discuss. And sometimes challenges can feel insurmountable. However, there are some challenges that we are only going to solve if we solve them together. Few problems in healthcare are solved by one person alone. And it's only by having difficult conversations that we can change things. We change the conversation, we change the action. And I've noticed that sometimes all of us across the NHS and care system often change the language, but it doesn't always follow through in the change of behaviours. Actions speak louder than words. And you might ask me, well, what are the difficult conversations? So let's try a few. The big one for me is we have to value our people. But the truth is, we don't always do that. According to the last NHS staff survey, a third of staff say they feel burnt out because of work. Burnt out. Nothing left in the tank. Too many of our colleagues suffer discrimination, bullying and harassment. The Workforce Race Equality Standard Survey 2023 has shown clearly the increase in BME staff receiving harassment and abuse. We're only just starting to tackle discrimination against people with disabilities and people from LGBTQ+ communities. Our data's got to improve. Our actions have got to improve. We must act on the data. No amount of abuse is tolerable, and yet we have tolerated too much of it. Let me be clear, there's no hierarchy of oppression. So when it comes to LGBTQ+ colleagues, we stand for people being able to bring their whole selves to work, and I will never apologise for standing in solidarity with them. A safe staff group equals a safe working environment. On top of the emotional, psychological cost to individuals, there's huge financial costs, and the RHO are going to produce further evidence of the cost of racism to the whole NHS. But the consequences of bullying and harassment in the NHS alone cost the service in England £2.28 billion. £2.28 billion. When did we decide that this was an acceptable way to spend money? But this is only going to stop if we talk about it together. I want to be clear. Things can change. There's hope. I'm saying this to help us all achieve the change we want to see. We need a workforce that people want to join and stay part of. Data from NHS England shows that 15,000 nurses resigned from health service in the year to March 2022, with 4,000 citing work-life balance as their reason for leaving. Staff across the NHS, England, Wales, Northern Ireland, are now 3 times more likely to quit due to issues of work-life balance than they were a decade ago. Yeah, we want a strong, safe, diverse and valued workforce. And I do welcome last week's publication of NHS England EDI improvement plan. We need to offer critique to each other. We need to talk about how this will be delivered. It's not about how we write things. It's about how we do things. But I want to go further as to why it's vital to patients and citizens that we talk about these difficult issues. We need a workforce that reflects the communities that we all serve, because that's part of how we will tackle the deepest health inequities and inequalities, because the NHS workforce is the community. A strong, safe, diverse, valued workforce is a key part of how we prevent illness. For me, there's no place for any perception that tackling inequity and inequality is an add-on or an optional extra. Reducing inequalities and inequity benefits everyone. It's core business. There's strong evidence that where an NHS workforce is representative of the community, that it serves patient care and the overall patient experience is more personalised and everybody improves. If you look at the MUSE model, it stands for Multilingual Emotional Wellbeing Service. It's been carried out at the Royal Borough of Kensington, Chelsea as an example. It proactively addressed inequality in healthcare, working in partnership with the voluntary community sector, providing support workers, one-to-one sessions with people who these people understand both the language and cultural barriers to accessing health and social care. Over 3 years, they reached black and minority ethnic people experiencing emotional and mental health difficulties. It led to 100% of users reporting an improvement in their health, a reduction in use of secondary care, and for every pound spent, £3.20 is attributable value that was gained. An ICB led an HSJ award-winning communications campaign that led to a huge increase in COVID vaccination levels amongst BME groups. The comms director says that work would probably not have happened. This work wouldn't have happened if it wasn't for the fact that she herself was from a minority ethnic background, highlighting the need for diversity amongst senior leaders, which brings me on to leadership itself. We're all leaders here. We're in all this. Where in all this do we hold our leadership practice to account? Do we know what good looks like? In order to have healthy communities and health systems, we need to understand our own leadership practice. Do we know what good looks like in delivering population health? And it's why the Confed offers numerous practical leadership development opportunities to help our members become better leaders, leading everyone, everywhere, all the time. Are we having the difficult conversations about what kind of leaders we need to be now? Now that we work as a health and care system, nationally, locally, and at place level. Sometimes, I've got to be honest, it feels as though we work against each other, fighting turf wars. How do we address this? Colleagues, we are the system. We're all system leaders. And I know, and you know, leadership is hard. It should be. I don't envy the job that my friend Richard or Amanda have to do. I really don't. It's not easy. It's not easy. Although me and Richard had a good laugh, didn't we, yesterday, talking about all sorts of things. It's tough. It's tough. And if you just want to, I support them 100%. It's an and world we're in now, not either or. But I also see the role we all have in helping articulate what the centre could look like in order to make the whole system work. Colleagues, we get the leadership we deserve. So let's have the conversation about what we need from the centre and what the centre needs from us. Real talk. There aren't easy answers. The answer can not only be about more acute beds, even though we still need more acute beds. We're still not at the European average. How do we achieve a social care system that works for everyone? We have an overwhelmed primary care service, mental health service, community service. We're reliant on the voluntary community and social enterprise colleagues. How do we better include them? How do we do this together? And as Matthew Taylor will say in his contribution to the conference later on, we need to say more about building a new social contract with the people that aren't in this room. Reset the relationship between the public and its NHS and social care system. No easy answers, but let's have everyone in the room in those conversations. Let's get stuck in to the really gritty issues. Are we talking enough about the parity of esteem so that people with complex mental health issues get equal access to health services as people with physical needs? What about the technology challenges? What about AI? I've seen both good and bad examples of it. What are the opportunities and the risks? Are we really engaged enough in the big debates? How do we prevent a two-tier health and care system? And you all know what I mean. The hard conversations we sometimes avoid, let's get them out in the open. Because as I say, the future is decided by the things we don't discuss. I want to end by saying again that I'm really pleased you're here. Really pleased you're here. I'm looking forward to what I too can learn from you. And when I look at you, it gives me confidence. When I talk to you, it gives me confidence that our NHS will be here in 75 years' time, used by the public, respected by our communities and colleagues who are the public. For so many of you, this was never just a job, it's a vocation. Let's tune in to how we make the most of that calling. So please, get talking. Have those tough conversations. Help us solve the big issues together. Thank you. Now, I'd like to hand over to my colleague and friend, Richard Meddings, Chair of NHS England, who will speak before you hear from a very inspirational person, George Webster. Richard, the floor's yours.
Thank you, Victor. So thank you, Victor. I stood here a year ago, very, very new to the NHS, as an outsider to the NHS, and actually I do still feel, 14 months later, pretty new. Although I have in that year had the great privilege of meeting and visiting trusts and systems and many, many primary care practices, the academies, and so I've tried to get to meet as many of you as possible and to get a much better real understanding of the NHS from what I had in my sort of run into the role, which was sort of, if you like, external research based. And what's one of my main takeaways? I think that I remain every day amazed, absolutely amazed at the sheer volume of the service provided by the NHS to the population of England. Absolutely amazed by it. Not just the volume of it, but also the quality of it. And when I go into the front line and I observe the level of care and provision, again, I'm humbled and amazed by it. Now, we're in our 75th year, and of course it will be celebrated, it deserves to be celebrated. But the more important thing for me, actually, is to think about this as a moment of high focus, and how do we think about the choices we make that position us for the next 75 years. And later on, I'm going to talk very briefly about how the NHS England board thinks about its agenda and its strategic agenda. I recognise that we're under very real pressure at the moment, huge pressures. The system all over the place actually is facing very real challenges, not just the immediate challenges we have with industrial action, but more broadly in terms of the rising pressures on our services as provided. And as I say that, I'd just like to call out primary care, because I don't know how many primary care practices I've now visited, 25, 30 or so, and I often sit in reception and just watch for a while, and I see the pressure on our primary care practitioners. And it is the most amazing, I think, vocational career to have embarked upon, not just if you're the GP, but actually as a worker in those practices. And I think we often forget that they are our insurance policy, our front door, and they manage 93% of the population's health needs. So it's a call out for them. But going back to the volume, if we think the population of England, which it is 57 million, the NHS does 1.1 million GP primary care practice appointments every single day, 345 million appointments every single year. We do 125 million outpatient appointments every year, 560 million patient interventions or contacts. There are 1.6 million mental health interventions every single month. 1,600 babies are born every day. I said about the volume, it is amazing. And on cancer referrals, I think we do about 240,000 every single month, and about 30,000 people enter cancer treatment, having been diagnosed and gone to have that referral. And it's an ecosystem. And coming in as chair, actually, the interesting thing is working out how to deliver strategic change through an ecosystem. And it's often misunderstood. It's not a dreadnought. It's not a single entity. It's actually a flotilla of different ships, different vested interests. So how do we get them all to cooperate, collaborate, point in the same direction on key priorities? And that is a challenge, and particularly with the hard boundary that we have created as human beings between health and care. So how do we actually manage across, to and fro, across that care boundary? And Victor's comments around primary care and the care boundary and working together in health and care through the ICBs and ICPs, I think that's a really, really important evolution. What's the essential challenge the NHS faces? Well, I think it's exponential growth in demand into an undercapacitized system. And if we take those two parts of that equation, we think about the exponential growth in demand. So population growth. The population of England has grown by 7.5 million since the turn of the century. So 15% or so growth in the last 20 years. We're aging. So we have seen a 30% increase in over 70s and a 65% increase in over 70s with comorbidities. Mental health last year surged. Children, young people's mental health presentations were up 39%. And obesity. 28% of the adult population is obese. It triggers 13 cancers. It causes cardiac issues, diabetes 2, musculoskeletal issues. And we have an obesity, real obesity challenge in our population. And then our brilliant researchers, scientists, clinicians, they forever find more ways the human condition can go wrong and ways to treat it. And so actually what I might call in the private sector, our product development is world class. So we develop ever more ways to treat a growing range of different conditions. So demand is growing exponentially. And what a capacity. You know the stats as well as I do. Workforce, 133,000 vacancies, 15% fewer doctors, 25% fewer nurses than the OECD average. Workforce is the bedeviling challenge for many of the other issues that the NHS faces. Beds, 100,000 beds in our acute hospitals. Relative to population, it's a third the beds of Germany, half the beds of France and Italy. Scanners, less than half the average scanners, MRI and CT scanners, for the OECD. So those are capacity challenges we have, and demand continues to grow. So what do we do to try and get that equation to solve? Well, we have to invest in new ways of working, we have to invest in technology, we have to invest in underlying capacity. When I took the role, one of the reasons I took it was I really liked the integrated care system structure, that direction. I think it's absolutely the right way to go to devolve more autonomy and accountability and authority to the integrated care systems. And they're almost a year up. Clearly, the genesis of them have been running for many years, but they're almost a year in existence, and we've already handed commissioning of many, many services directly to the ICS. And the brilliance of them is their ability to work with local authorities and the voluntary sector essentially across that boundary, and to be very close to the communities that they serve and to understand those communities. The other thing, as a sort of a realization, is the way that the NHS continues to evolve, continues to innovate. And it is a very different NHS today certainly than it was 75 years ago, or 40 years ago, or 20 years ago, or even 10 years ago. So one of the 10-year examples would be that we today are doing double the number of cancer referrals that we were doing a decade ago. And also the way that we provide service and support to the population has continued to transform. So one of the things often lost in the commentary is the continuous innovation, transformation, and evolution of the health service. So I said I'd share with you how the board is currently thinking. And like every board I've been on, many private sector boards, you have an immediate set of issues. The more short-term operational challenges, those issues. And then you have the longer-term strategic questions that you have to engage with. So I think about the immediate issues. Our next board meeting is in Birmingham in the end of July. And one of the things we're going to do is look very hard at our planning for winter. Here we are. Well, I can't see the sun today, but pretty hot summer. And actually, we're already, earlier than ever before, planning for winter. And we're going to give that a really good look. Are we ready? How are we engaging? What are the steps we can take to give us the best chance to manage through winter? Including when I was talking about bed capacity. Again, I was struck by the fact we run at 93% occupancy levels in our acute hospitals through the summer. And then we have to face the winter flood, the winter surge. So how do we think about creating that capacity ready for the challenges of winter? So that's an immediate challenge the board looks at. And the others are urgent emergency care, access to primary, certainly the waiting list, the elective backlog, and then cancer. And it won't come as any surprise to anyone in the room, I think, that each of these areas are subject to very intense engagement with the most senior levels of government, where we get huge support. Coming to the strategic questions. I don't know how many people would know this, but the NHS England has 130 objectives. 130. And 110 of those are in primary legislation, regulation, or statute. If I broke down the technology objectives, which is a relatively small number of those, they actually break down at the next level into 256 ministerial targets that NHS England is asked to deliver in the space of data and technology. So how do we deal with that? We have a phrase, increasing use phrase, which are, what are the enabling priorities? So what are those priorities, if you choose amongst the objectives, are most dynamic in terms of their impact on the array of other objectives that we have? So which of the priorities are the enabling priorities that, if we get right, enable other objectives better to be hit? So what would they be? There's one immediate one, which might sound a mix between short and long term, which is a merger. And that merger is of the 5 entities at the top of NHS England's infrastructure. And it's not just the merging those entities themselves and how they govern, it's actually taking out between 30 and 40% of the headcount. And we're currently at around 36.5% headcount reduction. And why are we doing that? We're doing it because we want to decentralize, debureaucratize, and enable the devolution to the ICBs and ICSs, and essentially reduce the head office burden. In spite of the brilliance of colleagues who work hugely hard at that head office, we want to debureaucratize, decentralize, and produce a smaller but more expert centre. So it's a key immediate task, but it's how we do ways of working after that task is completed. The second is continuing to give support to the emerging ICSs, 42 of them, all very different. They face different provider patterns, different local authority patterns, different communities, different populations. They take different approaches. Their boards are often in different shape. So they're all emerging and maturing. So we want to support that. The long-term workforce plan, which Victor alluded to, is a foundational piece of strategic work. And it was a very good piece of work done by Amanda and the team in consultation with think tanks, in consultation with Confed, in consultation with many people probably in this room or organisations with whom you work. And I think it's a really good piece of work looks at productivity, it looks at technology, it looks at skills mix, it looks at need, it imagines our world in 5, 10, 15 years' time and says that's what we need to drive to. So once it's published, actually that's just a start. The strategic work and the support is the execution, the capacitization of that workforce plan. Next item on the agenda is capital. This is a difficult discussion. We currently get capital of about 8 billion a year. Our backlog spend is 10 billion. We're spending more on backlog maintenance than we're receiving in new capital. We do need to find a way to capture, persuade Treasury, but also DH and number 10 about the capital need of the NHS, in addition to the new hospitals programme. And we will be given, essentially, the responsibility for the new hospitals programme at the beginning of July. 1st of July, the new NHS England will be given responsibility for the new hospitals programme. Technology is really important and very difficult. I often go to functions. I meet many medtech companies, very able, very good. The question is how we scale them. And I often say the issue is with so many of you, how do we scale? And so we've got to make some prioritised choices about what technology we go with. And this year, led by Tim Ferriss and his team, we are out procuring the Federated Data Platform. It's a really important step forward, and we would hope to award that in September. We're increasing the functionality of the NHS app. We're looking to develop a very clear target architecture, which should exist for NHS systems, and engineering principles, which matter hugely for IT delivery, and EPR, electronic patient records, in over 90% of GP practices by the end of this year. Get that delivered, and then lots more work, and we start to make real changes. And then lastly, primary care. Primary care, we need to transform, we need to support. I said earlier, it does 93% of the population health needs. We spend between 9 and 13 billion of 158 billion on primary care. We need to simplify our approach, we need to manage by outcomes and not inputs, and we need to look at options and not compulsions. But it's really quite clear that we need, with some urgency, to think hard about the strategic future of primary care. So a year on, and on a personal note, I came in fully believing in the underlying principles of the NHS, and I still absolutely believe they are the right principles. Accessible to all, free at the point of delivery, primarily funded through taxation. The way a society should be judged is how it looks after, in this instance, the health of its people. But I also recognise that we face very real challenges, and those challenges are fundamental to the way we operate, the way we're organised. We have to recognise those and not shy away from them, but at the same time keep a sense of confidence and optimism about our ability to make the right strategic choices. And we need to recognise that we can benefit from a world of ever faster technology development, of innovation. And today we have an NHS which is no longer the NHS of the iron lung. It's the NHS of virtual wards. It's the NHS of whole genome sequencing. It's the NHS of lung trucks, of semaglutide, of Grail. It does, as I said, twice the cancer referrals that it did a decade ago. So how we choose our strategic priorities, how we execute upon them in collaboration with each other across a multi-headed system, I think that's what will give us the opportunity and the confidence to set up the next 75 years of the NHS. Thank you very much for listening to me.